Well, I am very happy to introduce a rising star in our department, Anna Bailey. Anna first came to the University of Rochester Medical Center in 2021 after completing her PhD at George Mason University. And she's had an ongoing interest in young people with suicide concerns and um, and how the body uh, may impact on those suicide concerns. She's going to be talking with you today about the ideas that she has for really trying to move the field a little bit over time. It doesn't happen overnight, but with good research, ideas, trying to really impact what we do to prepare people for crises. We all kind of have this intuition that maybe there's a little more we could do than a safety plan, as they're done right now. And so her evocative title, Does Safety Planning Need a Makeover? I know sort of probably to many of us, just at the gut level, the answer is probably yes. But let's hear why. And Anna has told me that she has left ample time for discussion. So I'd encourage you to be really thinking about what you'd like to discuss about this, not just questions, but also comments, observations, maybe experiences that you've had that would be relevant here, because she's really going to leave time. It's hard sometimes when you deliver these because you have so much to say. It's hard to leave time, but she's said that she really has. So I'm going to be looking at some of those online questions, but we'll definitely take some from the room, and I'll be up when she's finished. So if you would welcome Anna, who is a senior right now, a senior instructor in the department, has an award from the Translational Science Institute, a career development award, and is on her way to being an independent funded investigator in suicide prevention. So Anna, thank you so much for sharing what you're learning and will learn with us.
That was so lovely and personal. I love that. All right, so thank you all for being here in person. I know that it takes time and effort to even just get here. So thank you so much for joining me today, and thank you for everybody who's online. So as Tony mentioned, I study suicide prevention among highly vulnerable youth and young adult populations. And so this intuition I've developed across my clinical work as a clinical psychologist and a researcher is that crisis and safety planning needs a biopsychosocial makeover. For too long, our crisis planning has focused on psychosocial strategies that get used just at the moment of crisis. And what I'm suggesting here is that a safety plan, or what we eventually may call a health and safety plan, can have changes to how people eat, sleep, move that could make a suicidal crisis less likely to happen. And if a big stressor does come up, we can help people to be more prepared, have the resources to use their safety plan. So I'm going to start by walking you through a little bit what I mean. Through the work I've done so far, you'll sort of see my thought process as it unfolds, and then thinking about how we can change the way that we plan for crises. So who among us in the room has done a safety plan before? Great. So you've seen probably this or something very similar to this. When a person is in crisis and presents to us, this could be an inpatient, outpatient, CPET, primary care settings. A big focus is on maintaining safety. We want to prevent harm from happening to somebody. That makes a lot of sense. And our first line of defense is literally called a safety plan. And so for those of you who have not done this or who are less familiar, you can see that there are multiple steps. It's a brief intervention. It was designed not to work on its own, but to be sort of the first thing you do to identify warning signs that might signal an impending suicidal crisis, identify internal coping strategies, things that people can do on their own to help reduce distress, Then identify people and settings, things that can distract them in that moment. Identify family and friends who can help resolve the crisis. And then a list of professionals, agencies, other settings they can contact for immediate crisis support. And then finally, we also include means safety, making your environment safer, removing access to lethal means. And again, this was designed not to work just as a one and done intervention, but to be something you do at the start, to give somebody something to hold on to while you then move forward in treatment. And we have research that shows that safety planning does help when it is done as it was intended, safety planning plus follow-up, and it can reduce rates of suicide attempts. And there are certainly people you may be able to think of times that patients have come to you and said, I was really stressed and I did it. I used my safety plan. I remembered this time. And it's so great when that happens. But I'd like to make a few points about their limitations. So first, there is some mixed evidence that shows that safety planning may or may not work in all ways for all groups. And there's a recent meta-analysis that just came out hot off the press in 2025 that really shows that for youth in particular, it matters how you do it, and it can be ineffective when it's not done as intended. There's also this big focus on the moment of crisis. With the exceptions of means safety, where you're removing access to things in your environment, all of those strategies are meant to be done in that point of crisis. This means that we are relying on our patient in the moment to remember they have a safety plan, find it, take it out, and then actually be willing to pick one of maybe 5, 10, 15 strategies that we've pulled from a laundry list while they are actively thinking about suicide. And think about that person sitting in your office. Do you ever have somebody sitting there and you can just feel the energy rolling off them? You're like, I'm just taking this on. This is so much. The safety plan doesn't account for that physiological arousal, what's happening in the body, that state of emotional intensity. And you are asking them to remember to find this, take it out, and pick a strategy. And that state hugely impacts whether or not they'll even use the safety plan, whether they have the capacity to use those things on their list. So there's a big miss in terms of things that we can do before the moment of crisis. Our intervention approach right now looks like this. You make the safety plan, and then time passes. And you might be doing things in therapy. You might be targeting longer-term issues that get at the root of suicide-related concerns. You might be addressing barriers to treatment. It's not that you're doing nothing. However, some people come to our office and then we never see them again. Or you see them in CPEP and you know that they come around and around and around, but they're not engaging in longer-term care. So we give them the safety plan and then we wait. We wait for the crisis to occur. And then they take the safety plan out, maybe, and hopefully they use it. We have an opportunity to help prepare vulnerable people for significant crises and stressors that will inevitably happen. Now, I think a common experience for us as providers is to make that safety plan and think, is this it? And you get nervous, right? You have that feeling of like, I really hope they use it. I don't think I can do much more, but I gave them this and maybe please they will use it. And I have to wonder, is this really the best thing we can do? So with all that together, I think it's time to really be thinking about how we change the way that we plan for safety and help reduce vulnerability in crisis. And so let's think about the body. Think about that heightened emotional state, that arousal, that rolling tension. What's happening when this stressor occurs? So certainly, while not the only stressor, social threat is a primary precipitant of suicide attempts. We see this again and again. It's a pretty solid fact in the literature. And so when I think about this and I think about how do I integrate my understanding of suicide risk with what's happening in the body, the theory that I most heavily work from is called the social safety theory. It's very complex. I'm going to give you just the key points that are related to us today. Humans have a social brain. It's oriented around social safety and social threat, and we are incredibly sensitive to those social threat cues. In fact, we have a specific biological pathway that works together to make this happen. So this is called the social signal transduction pathway. Doesn't really matter if you remember that, other than I'm going to mention it a couple times. I want you to think this is the way in which our social world gets under the skin. And so this complex pathway includes the sympathetic nervous system, the HPA axis, the vagus nerve, meningeal lymphatic vessels. A lot is involved. And a few things can influence this process. So one of that is chronic activation of the system, but another is the way in which we treat our bodies. So for example, sleep, diet, movement, all moderate components of this transduction process. And they do so by acting either directly on inflammatory processes or by acting on other components of the pathway that in turn impact inflammation. And this dials up sensitivity to perceptions of social threat. And so in addition to being a key player in this process, research has also shown a link between inflammatory processes, suicide attempts, and death. Now, I personally find this process fascinating, just the way in which we take this on and it plays out. But something that I really struggled with initially when I first started down this line is how do we leverage this? What do you actually do with that? How do we change things? And I've been very fortunate to have just a really incredible mentorship team. So you saw Tony already right up here. Tony Pisani and Steve Silverstein have been my primary mentorship team since I was on postdoc here in psychiatry. And more recently, Kathy Hefner in the School of Nursing, who is a psychoneuroimmunologist, has joined our team. And so they've really helped me to think about what do we do with this? And Steve has actually shaped so much of biopsychosocial research that he is not here because he's receiving a Lifetime Achievement Award for that. That's pretty incredible. When he said, I can't come because I'm getting this award, no big deal. And then it says Lifetime Achievement, like that's pretty incredible. And Kathy has encouraged me to think about psychoneuroimmunology from the perspective that you take. So what do I mean by this? Are you the P? Are you the N? Are you the I? I'm a psychologist. So I'm thinking of this from the perspective of a psychologist and how is this related? And then Tony just has this incredible eye for what's happening in the field, a really great pulse for what are the upcoming health trends, what are the shifts in our national priorities. And so when we think about this, we're putting all of this together and thinking, what do we do? And the question I ask is, can short-term changes in sleep, diet, and movement actually help to mitigate suicidal crises for vulnerable people? And this is an idea that we still want to test. There's a big program of research. This is what we'll be talking about today. Can we influence these pathways, the same pathways that are linked to social threat cues that are relevant for suicidal crises? And indeed, current national priorities, NIH, and elsewhere are all emphasizing nutrition and health behaviors as central to preventing chronic disease and suffering. I'm simply asking, can we leverage these same health components for suicide prevention? So I'd like to go back and talk a little bit about the work I've done so far. How did I get here? When I first started down this line of work, again, I'm a psychologist. I'm not a biologist. I'm not an immunologist. And so a big question people would ask me, both at work and at home, is why does it matter what the body's doing? You're just going to ask them how they feel anyway. Has anybody ever been asked, like, don't you just say, how does it make you feel? I do ask that question a lot. And so an early thought I had was whether inflammatory responses can tell us something about who's at greatest risk, or what kinds of people, what kinds of inflammatory responses are most likely to result in suicidal thoughts and behaviors. And this is really more thinking about assessment and identification. And this was some work I did actually in grad school that I then kind of continued through and published as a postdoc. But this was a study where we had a sample of 42 young adults in college. They all had past month thoughts of suicide. We had them come into a lab and we did a social lab stressor, where essentially we created an environment where they were slowly rejected by Confederates. So it's called the Yale interpersonal stressor. You put two Confederates, two trained undergrads in a room with the participant, and you ask them just like, what do you do with your friends? How do you make friends? What do you like to do on the weekends? And slowly over time, the two Confederates will bond with each other. They'll laugh, they'll shift their bodies near one another. And they'll do things to subtly and increasingly exclude and reject the other person from conversation. Kind of hurts to watch, actually. There were a lot of proper debriefing procedures. But we shaped this social environment in the lab, and we collected saliva samples to measure their pro-inflammatory response, specifically IL-6 and TNF-alpha, to this task. The idea behind this was, can we use this as a proxy marker of what might actually be happening in the real world? So what is happening in their bodies when they experience a similar kind of rejection? From there, what we did is we asked them to do smartphone surveys, ecological momentary assessment, 6 times a day for 28 days. We asked them a number of questions. They included things like, have you had thoughts about suicide? Have you had thoughts about killing yourself? And also whether they've experienced any number of negative peer events. And so we quantified all of this. We used multi-level modeling, and essentially what we were looking at was to examine whether the relation between negative peer events and the presence of suicidal thinking was impacted by that pro-inflammatory response. So did you see different patterns based on that pro-inflammatory response? There were a number of other things that came into here, but this is the finding that I'd like to highlight today. So one of the preliminary findings was that for any given person at any given assessment point, an increase in the number of negative peer events they've experienced in the moment was associated with increased odds of having suicidal thoughts at the next time point. So you experience an increase in peer events, the next time you're asked, you are more likely to have suicidal thoughts. But this was only for people who had very, very low levels of IL-6 activity, and not for TNF-alpha. Now, we had a number of questions and kind of methodological constraints that came around with this. So there are a lot of caveats and stars. The point I'd actually like to make is that this led me to think, is there a better way to get at the way in which we think about inflammation? So some early work, but maybe we need to rotate the model a little bit. So around this time, I was transitioning to UMC. I was starting on postdoc. And a big focus that I really appreciate here is this eye toward clinical applicability, the patients we serve, the settings we work in. And as I mentioned, Steve Silverstein is one of my mentors who has done an immense amount of psychosis risk research. And all together with Tony and Steve, we narrowed in on this specific subgroup of young people who are particularly vulnerable. These are young people who are at clinical high risk for psychosis. And so this is a syndrome that is characterized by a decline in social, academic, occupational functioning, onset of attenuated positive symptoms of psychosis, think kind of subthreshold levels of hallucinations, delusions. They also may experience negative symptoms of psychosis. And these symptoms are highly sensitive to both positive and negative stress. And so this is why we shifted our focus here for a few reasons. In addition to the sensitivity, this group just has incredibly high rates of lifetime suicidal thinking and suicide attempts compared to their peers in the general population and their peers in other psychiatric settings. So lifetime suicidal thoughts at about 77%, close to a third have made at least one suicide attempt by young adulthood. And for this group, their symptom presentation complicates the way in which they interact with the world. So imagine, for example, that you're having kind of these low grade, but more than a lot of other people, symptoms of paranoia. How is that going to complicate or heighten your social threat response? And in another important consideration is research has shown elevations in inflammatory processes in people at clinical high risk. So they're, in a way, an ideal subgroup to study this stress, inflammation, suicide risk process, and arguably stand to benefit the most. And so Steve and I replicated and expanded some of these findings in a recent paper. This was drawn from a large multi-site study of psychosis risk. And we specifically focused on 2 groups of people within this study. People who are at clinical high risk, and then a help-seeking comparison group. These are young people who have another DSM diagnosis. And first, we looked at rates of suicidal ideation. This was just dichotomized as, in the past year, have you had thoughts of suicide? And they were higher in the clinical high-risk group, nearly double, so 45% as opposed to 25%. We also looked at rates of interpersonal difficulties. So this was captured both as global poor functioning and also number of interpersonal trauma domains experienced a lot across the lifespan. And we saw greater domains of interpersonal trauma and poorer global social functioning in that clinical high-risk group. And this isn't really a surprise, but it does show that we can replicate this finding. And finally, we looked at whether interpersonal difficulties predicted the odds of having suicidal ideation over the past year. We also looked at whether diagnostic group moderated that relationship. And the idea was, is there something different that kind of dials up the link? Essentially, what we found is more interpersonal problems were related to greater odds of having suicidal thoughts, but this was not moderated by diagnostic group. And for me, what this means is really there's sort of a transdiagnostic takeaway. Something about that relationship between interpersonal stressors and suicide risk is mirrored in both the help-seeking group and the clinical high-risk group. So for now, we can proceed with the idea that we can use some of our existing suicide-related theories to apply thinking about suicide prevention specifically to clinical high-risk young people. So from here, we started to think about how do we strengthen the social side of biopsychosocial? Again, as a psychologist, I'm often thinking, what can I change in your landscape? And we thought if we could get a good understanding of how clinical high-risk young people's social landscapes looked, then we could treat inflammation as a biological metric of that social stress. And we could start to think about how to bolster the social portion of this biopsychosocial approach. We wrote a nice little brief report describing our ideas, our thoughts around this. And we started to think about how can we incorporate the social network, the web in which people are embedded. So not social media, but really your social landscape. Here's an example of what that looks like. So the black dot in the middle is the person of interest. And the gray dots around them are people who are close to them in their life, people that you might go to for help or support, people you might socialize with, people you might live with, people that you spend time with. And the way that this network is created is we ask you, how strongly do you feel connected to each person in the network? And then how connected are those people to one another? Do they even know each other? And are they close to one another? And so you can quantify a number of different parameters. You can see the dark line means that they feel closer to another person, and the dotted blue line means that they feel not as close. And we use kind of this crude, just especially or not especially close, but it does allow you to create these network maps. From here, we did some pilot work. So we did 2 preliminary studies. One is ongoing, collecting data out of our Intercept program. So the Intercept program at URMC, for those who are not aware, is embedded within Strong Ties. This is a specialty clinic for young people at clinical high risk for psychosis. And it is coordinated by Tricia Kilborn, who is right here. I'll send you her way if you have questions about referrals or anything else. And so we've done 2 pilot studies now. One is completed, one is still ongoing. The first is a cross-sectional study just looking at social networks and markers of neuroinflammation in people at clinical high risk for psychosis. The second is my ongoing career development award through CTSI, where we've expanded this protocol. So in addition to doing some baseline assessments, we're doing a 3-month follow-up. We're doing some ecological momentary assessment. But all of these participants are recruited primarily from Intercept. We do get some secondary referrals from other CHR studies. So here's what the full battery looks like. I've highlighted in red those that are social related, in blue those that are inflammation related, and yellow in those that are related to suicidal thoughts and behaviors. And this will be relevant in a couple of slides as well. Those that are bolded are also administered across both studies. So first we do this personal network mapping tool. That's how we derive the network that I just showed you. We ask them questions about who they're close to and how close they are to those other people. We also administered a number of self-report measures on loneliness, perceived rejection, and emotional support, as well as the interpersonal needs questionnaire that asks about thwarted belongingness and perceived burdensomeness. So again, thinking back, social support, social threat. We've been collecting inflammatory markers in a couple of different ways. Right now, we're collecting serum draw for pro-inflammatory cytokines, but across both studies, we also have been using optical coherence tomography. Not going to go into super detail. I'll show you what this looks like in a minute. but this is essentially a retinal imaging procedure that allows us to try to create a proxy marker for neuroinflammation in the brain. And then suicidal thoughts and behaviors. From our preliminary study, we simply gathered medical record data of current and lifetime rates of suicidal thoughts, current and lifetime rates of suicide attempts. In the fuller, larger study, we are doing the full Columbia Suicide Severity Rating Scale. We're also getting a continuous measure of suicidal ideation. Now, in the fuller study using the ecological momentary assessment, we are also gathering some data on characteristics of the interaction, where we essentially take the people in your network and we ask you, have you seen those people in the last few hours? We are able to pull their data into their smartphone surveys. And then if you've seen those people, we're asking about the flavor of the interaction. So not just how much did I like this person in the moment, but how many people were present in the interaction? Did you feel like you belonged? Did you feel like you were supported? Did it stress you out? What were you doing? Trying to get a sense of, what do you actually do with the people? Do you see them as much as you say you do? Or have you identified somebody as a potential support, but you never see them at all? So I'll show you some very basic preliminary results, primarily focused on the social connection measures and the optical coherence tomography in just a moment. But briefly, for those of you who are have not seen somebody present on this yet, I imagine this will come back around in our department. It's a very popular metric and fascinating and actually quite interesting to learn. But essentially what you're doing is you're taking an image of the back of the eye, similar to an ultrasound. But this is the chunk of the back of the eye that you're looking at. Think, where does the optical nerve come in? How is the eye connected to the brain? Why does this matter for inflammation? That part. And here are a couple images of what those pictures look like. We can quantify neural layer thickness in a bunch of different ways based on those images. Now you can get other images as well, but this is just for reference. You can see that you sort of see layers, and we can quantify those. And that's what we're looking at. So in this preliminary sample, we have 18 youth and young adults, all from Intercept, who are hovering between 18 and 19 years old. I think our entire range is something closer to 16 to 25. And you can see the demographic breakdown, both for sex, gender, and race and ethnicity. We have a fairly diverse population at Intercept, and we'll be pleased to see that we do bring in a number of male participants, which are difficult to recruit in research, but we've managed to be able to do, and I'm going to give Trisha another nod for that, who is a really excellent clinical coordinator and really helps with recruitment efforts. So thank you, Trisha. Another thing I'd really like to point out, though, here are the lifetime rates of suicidal ideation and attempts in this group. So this is a collapse primarily from the preliminary study, but a little bit from the Career Development Award, which does recruit specifically for people with lifetime histories. So this is ever so slightly artificially inflated. However, the clinic rate of suicidal thinking, lifetime suicidal thinking, hovers around 70 to 80%. So it's not that far off. So in the sample, 16 of the 18 young people had reported at some time in their life having thoughts of suicide, and close to a half had made at least one suicide attempt. And here's what their social networks look like. So this is a subset of 10 people. And what might stand out to you is that they all look kind of different. So some people have a lot of connections. If you think kind of second row down toward the left, toward the right, this person, everybody is connected in some way or another. Some people only had a couple of supportive others. And you can see that in some ways these networks are heavily tied together, but there are a couple of people kind of floating in the parameters. And so we can quantify different network metrics from this. But something else that stands out to me is, in addition to just asking about their network structure, we asked what these people do for them. Do they make you feel supported? Do they help you get through the situation? Do they make it worse? That bottom one that I think is cut off says, do you go to this person when you're upset? And think back to what's on your safety plan. Who makes me feel supported? Who will help me get through the situation? Who might be a triggering situation for me? So 70% of these people did provide some support, but only 36% were helping the person get through the situation. So when you think about who are the people who can help you get through the situation, who can help you in a crisis, maybe a third of the people who are identified. And that bottom number, I do not go to this person when I'm upset, another third, 36%. And that's stark. So the people, the supports that we are drawing on, the things that we are relying on in the psychosocial safety plan are cracks. So even if you've listed somebody, the likelihood that you go to them is quite low. Now there's a lot going on here, but I'd like to highlight a few things. One, this is where the color coding matters. So yes, I like to have some color cohesion. Anything in red or that pink color is a social metric. Yellow is a suicide attempt. I didn't include suicidal ideation here because there were just so many people that it wasn't as helpful. And the blue are your optical coherence tomography derived inflammatory markers. And so I've kind of color coded them as well where they intersect. And our goal here, as Steve and I were starting to look at this, was not so much hypothesis testing, these a very small sample, but to really just examine the effect sizes. And for a visual representation, I've bolded anything that's an effect size at or above 0.25, just so that you can kind of get a sense of where are these correlations lying. Now things can change, stats can be sensitive, but on the whole, what we're seeing is this pattern start to emerge, where retinal thinning is associated with poorer social connectedness. Now, retinal thinning can indicate that you'll have neurodegeneration. So you might have had some chronic activation of inflammatory processes, and over time, those get degraded. So lots of stress, and now the system is getting worn down. And poorer social connectedness, less social safety, more social threat. So we're seeing this pattern emerge with retinal thinning, poorer social connectedness, and also retinal thinning associated with a lifetime history of a suicide attempt. So all of this was really focused on generating hypotheses, thinking about opportunities for intervention. And that brings me to my current line of thinking. So the big question for me still is how else can we affect the trajectory of crisis? And I think back to those networks. The things we've given people are only working so well. And I think back to how I've been thinking about inflammation up to this point as an assessment tool, as something that tells us who's at risk. But risk fluctuates so much. Our worlds are insane. So you move through the world and something comes out of nowhere and changes the way in which you're functioning. You might be having a great day and then a stressor comes about and it shuts you down. And so instead of trying to think, what will this kind of static biomarker or this proxy measure tell me about somebody's risk level? What's it going to tell me about who needs this intervention? Those are all important questions. These are questions worth asking. But the question for me, I think an important question is how do we use our knowledge of this biopsychosocial model to better prepare the people we work with for crises? How do we help them have better insight into their own distress? How do we turn down the dial on threat sensitivity? We can only do so much to remove threats. And in fact, we don't want to be helping people avoid things. You can only change so much, but you can work on dialing down the sensitivity. And how do we help them be better prepared to cope with those stressors in ways that are not harmful? And so I think this model lends itself really well to thinking about biological processes as vulnerabilities. So this brings me back to where we started, the makeover of the safety plan. And I'm suggesting that we target these biological vulnerabilities. So I want you to think back: sleep, diet, movement. These are health behaviors that impact inflammatory processes that shape how we respond to social safety and social threat. Now, some of you might be thinking, and a question I even ask myself as I kind of go around and around and around is, well, yes, sleep is important. How you eat is important. I should get my steps in. We all know that. It's not a surprise. My watch reminds me on a regular basis. It might remind me while we're talking. And you might be able to think of times in your own life when you've been really stressed and you can only control so much. And the things that help are focusing on getting a better night of sleep, on getting a little bit of activity, shutting off your TV, shutting off the media, and just focusing on yourself. But it's really hard to do that. It's really hard to say, I'm just going to tune everything out and focus on my body. And so we need to think strategically about how we're doing this. So I think it's important not just to say, well, yeah, I tell my patients they need to get a good night of sleep. I tell them to eat better. I gave them that handout. It's important to be thoughtful about our research questions, aligning them with how the biopsychosocial process plays out if we want the makeover to really work. So I think about this as, let's not be trendy, let's be timeless. You want to think about how the model plays out. So what do we do next? There's a lot going on. The longer I think about this, the more questions pop up for my own self. So I tried to break them into a couple of different domains. First, what comes next, and then where are we going? So the first step is that I'm preparing to submit a K-23 Career Development Award to NIMH, hopefully in February. And between now and then, we're trying to really refine these ideas, gather some preliminary data to support them, because the data we have right now is really focused on those psychosocial processes. We have the biomarkers, but how do we really gather the data that will best support this approach? And so we'll do some preparatory work, particularly through Intercept. So thinking back to that highly vulnerable population, the population that experiences a lot of stress, that have really high rates of suicidal thinking. And so focusing there first. And a number of things we've thought about, data that would be helpful to know are, what do people even think of this? So I'm sure when you're thinking about, I'm trying to do a safety plan and you want me to also add in some other things, or this person is in crisis and you want me to tell them to change this behavior. I'm curious, what happens if you tell a patient, hey, actually, these things could change the way you respond to crisis? There's a lot going on, but if you could change your response to crisis by making these shifts, what do you think? It's possible in my mind, I think, that if we shift away from just, let me give you a list to make sure you don't hurt yourself, and really think about, how do you be well? How can we treat you as a whole person who is worth being healthy, worth being well, even in the face of crisis? And so if I say to you, what do you think if we add some health behaviors into your safety plan and we try to get ahead of things rather than waiting for the crisis, mitigating that risk? If people are on board, that's great. That's an in to begin with. But we want to know what they think. Do they think health behaviors are relevant to their mental health? I can tell you anecdotally, we do see this in the clinic. People come in and they say, well, what about this diet? What about that diet? Well, I changed this thing. So people are thinking about it. People are thinking about, how are my health behaviors relevant? Will this be enough? Now, we often think about it in terms of, will it change the pattern of my symptoms of psychosis? But people have it in their minds. So getting a better understanding and really being thoughtful about gathering that information around, would you be willing to prioritize this in crisis? Other priorities, how is crisis responding going to you? How has it gone for you in the past? How is the safety planning process? Does it shift the way that you might have felt in the moment? I'm also thinking about some medical record data. So a number of our patients come frequently into CPEP. They're chronically in crisis. And so we have all of this medical record data available to us that describes what's going on for them in crisis. So another question that in particular we've been talking about is, can we leverage that medical record data? Can we compare people who are already seeing in practice at their time of crisis to other domains? And really thinking about what is changing in those moments. But across this larger program of research, we have 3 guiding questions. And this is years and years and years of work. But I think this is how we really want to be strategic in how we change things. First, do short-term changes in sleep, eating, and movement make a difference at the mechanistic level and for reducing crises. What I mean here, when I say mechanistically, think back to that social signal transduction pathway. Does it impact that path that matters? Things that are kicking off, processes that are being kicked off by that social threat. Second, what interventions will people actually do when they are in distress? So thinking back to that crisis moment, what we're trying to do is not be totally underwater, but even when you're not in the midst of that suicidal crisis, stressors are still around. You are still having a hard time. The people who come to us are dealing with all sorts of problems. And so are you willing to make these changes? And finally, if we can show that it actually is going to work, if we can show that people are willing to do this, how do we change clinical practice? Changing a practice in a single clinic is hard. Changing practices in a hospital setting is even harder. And there are a lot of hospitals in the US. I don't know how many, but there are a lot. And we've done it before, right? Safety planning is now considered a gold standard. It's part of JCAHO requirements. We do have whole system changes. So we can do it. It's just how? And that's one of our questions. And even within all of this, there are so many research ideas, so many important pieces that we really want to be asking. So first, target engagement. This is really big in intervention development. Thinking about if we shift one piece, does it move our treatment target? Asking people, if you make these changes, do we actually see reductions in crisis responses? Do we see changes in those inflammatory processes? Personalization is also on my mind. So what sorts of changes does any one given person need to make? Do you need to only change sleep for one person? Is it better to set goals that say we're just moving toward whole health shifts and every day try to approximate toward that? What does dose response look like? Are people willing and able? What are some of the moderating factors? One of the thoughts that Steve and I have tossed around that's come up in some of Tony's work as well is the idea of self-compassion. Do you have compassion and care for yourself enough to want to make these changes? And some qualitative work on how do you package this? What is the packaging that will help people actually be willing and on board to do this? And then some big dissemination and implementation questions. These are questions that are up every time that we try to change evidence-based practices. But how do we get clinicians on board who are stressed and the system is not aligning with the new practice? How do we get the information out there? What's the best packaging? And some ethical considerations, I think, as well. We want to change the way that we are coping with crisis, and we have some gold standards already. And I'm saying, let's do something differently. And we want to be thoughtful about what happens when we start to shift what we already do. At the same time, I think that there is a safe and meaningful step that you can already make in your own clinical work, adding a short health addendum to your safety planning. Helping the people that you work with identify patterns in their own health behaviors that make them more vulnerable to engaging in suicidal behavior. Thinking person-centered shifts in regular sleep and eating, small dietary shifts, daily movement. I do this in my own practice already. And so if you're looking for a resource in how to do this, what I draw from right now is the DBT model of emotions that highlights vulnerability factors that change emotion presentations. So it's in the emotion regulation module, and there's a set of please skills as well that target some of these processes. So you're really just taking these and you're applying it. Now, this is not a replacement for safety planning, but it's an early stage idea that's grounded in clinical intuition and preliminary evidence that I invite you to explore in your own practice as we continue to test these. And with that, these are my acknowledgements, all of the people who have contributed. Ian Sierra right here, who leads the Q Core if you need stats help like on those networks, our funding support. And I will pause here for the discussion that I promised.
Well, that was fascinating, Anna. Thank you so much. So here we can open up to questions from people in the room as well as online. I have an iPad with the Q&A on them, but we'll first allow people here in the room and while I pull up the Q&A. And go ahead. So please raise your hand. Segundo. Oh, you're telling me about that.
Oh, yeah. Sorry. I think this is so interesting because, we often ignore, I feel like, the health behaviors. One of the things I found myself thinking about as you were talking is how is it possible, or have you thought about trying to bring the behaviors in the therapy room, for example, right? Like, I mean, we do so much like sitting and talking with people about things, but like that's insufficient, as you said, like talking about, the healthy behaviors doesn't necessarily mean that people are going to change them. And so I often try to think about like sleep and food is hard, but like walking while you're doing therapy with people, or if they're in crisis, like, I don't know, getting up and doing jumping jacks or like doing some type of movement. So we're like teaching the skill as we're doing it and seeing how that helps people when they're in crisis, or even just give them the muscle memory to remember like, oh, when I was moving around, I like felt so much better. So I'm just curious if you thought about how you might actually, so like real life behavior change in the moment.
Yeah, I love that. And I would say, I love this, first of all. I would say this is something that I do when teaching most skills, or if it's possible to mimic it, even if we can kind of simulate some physiological arousal to practice using a skill when somebody presents in the moment and they're in crisis, doing that mindfulness for a moment to set in. But I really like the idea as well of not just saying, how do I practice using these crisis response techniques, which are important, but also, yes, if you are not moving around at home and that's something we're working on, let's take a lap while we're having session. If you're virtual with somebody, how can we maybe walk through your bedtime routine or set up your kitchen, your meal prep for the week so that you are getting these things together. And I think we do this in other approaches. I think of some eating disorder treatment where sometimes you're actually including eating in the session or in programs. These are ways, things we could also be thinking about from higher levels of care in an inpatient setting. I know we're opening up now that quad, but can we start doing this and getting people on the right track with those health behaviors while we have them in these higher levels of care and bringing them out? So I love that idea.
Segundo.
Hi. Can I call you Anna?
Yes, you
All
may.
right. So as you were talking about this, I think these are great ideas. And if you don't know me, I'm in brighter days. I think that the idea, these things can be applied readily. So, but one thing that came to me is like, okay, this issue of relationships, right? Is that, for example, when I hear you, right, you were introduced by Tony, and I know Tony, and I also know Dr. Silverstein, right? And so now I know that you know them, and they're highly credible people. And now I look at you and I say, what you have to say seems relevant. So what I'm going to be is I'm going to pay attention to this, and most likely I want to learn something about this, and I'm going to apply this in the future. So what I'm thinking about this is like right now have developed like a sense of trust that I can now use this information you brought and universalize it or takes it from here to brighter days. And I'm thinking about that in terms of relationship with the kids, right? Or this case with kids, probably you adults and stuff like that. It's like, what are the relational networks that you create that they feel like what you are teaching them is relevant, and whether that relevance translates into them applying what actually they're learning. And it occurred to me just sort of like, to me, this is a very interpersonal, relational approach that you're taking. That, for example, when you say, well, you need to sleep and to eat and these, that actually, they believe that this really matters. And because, I believe that you care about me, and I care about you, and this relationship is important. That's kind of my contribution.
Yeah, that's a really interesting point. Actually, one of the things I think about sometimes is sources of knowing. So what are all the ways in which you know something? So we approach this as health professionals, but you might also know something through religious practices, through your social circles. And so I wonder if one of the questions on the larger scale is, what are the ways in which we infuse this information? So in our center, we do, so along with Tony and Peter Wyman, they do work in the school settings and really making changes and capitalizing on these networks to shift people together. Another thing that actually came to mind is maybe in the context of Brighter Days, you can only do so much because you have no contact with those other people. But I think about, where do youth in particular get their sources of information? I don't know how many of you feel pummeled by health videos online. And so it's popular. And so how can we capitalize on what's going on in their broader world? I'm aware of some research that's done around something called memetics, where the idea is that you're actually working with the people who are influencing at a population level to try to shift behaviors. There's a lot that goes into that, but I think the approach that you take to making these behavior changes may depend on at what level you're intervening on them.
Yeah. And maybe some of the people in those networks will be really important for that. And I think Ian had a similar intuition. I think we all have Ian's work. He was bringing together a youth-nominated support network over text messages to try to have them interact more. This idea that we listen to people that we know, that we like, and that we trust. How can those things be leveraged towards these things that are hard to change? We have two other questions here. One from the esteemed Dr. Kim Van Orden. And to sum up hers, she's wondering, definitely we need to have this be part of treatment, but why do you say that it should be part of a safety plan?
That is a great question. It's actually something that I've wrestled with a little bit. And I think that gets to the idea of, it is embedded in some of our treatment approaches. And so this idea of, if you're safety planning and then people are coming to treatment, you would be probably working on these things anyway. So the reason why I think it matters for crisis response planning is that, one, people might not come back. And so you might not have the opportunity to give them that same level of intervention across a longer span of time. But the other thing I think about is, for some patients who are constantly in distress, it can be really hard to get to the skills that will change these behaviors in session. So you have somebody who comes in every week with a new crisis, a real crisis, but you never get to the interventions that are going to get at the root of the concern. And so I think about this. Part of that is, how do you structure session? But if you can set the tone at the beginning that we are going to make these shifts, the idea is that it will dial down that distress long-term. And so I think it's important to be starting off. If you can only give people a couple of things in a short amount of time, is it possible that actually by changing those biological vulnerabilities, you are changing the trajectory of distress?
Another question, really interesting one. From Tanya Tran. And this actually will, I think, dovetail a little on what Segundo was asking, but from a different perspective. What Tanya was wondering was, how can we ensure that these kinds of health behavior improvements are known to therapists and actually come into treatment? And what she was wondering was, is this an opportunity to have nutrition experts or dietitians or others on a multidisciplinary mental health team? Do we need our mental health teams to be biopsychosocial as well?
Yeah, I think we may. I think that's one potential. And I think this is where, kind of actually also similar to Kim, it's not that this information is brand new, different. I haven't discovered a new body part. I'm just thinking about, how do we leverage the tools we already have in a new and different way? And so maybe an interdisciplinary treatment team really is the approach that we need. I think of like MIPS, for example, that could potentially be a really good model for how to do this, because they are really focusing on this true approach. Some of this is going to be about the dissemination and implementation, the intervention packaging. So I think these are all good questions that are worth addressing.
But it is funny that we definitely think that psychologists should be on the medical teams. We think, but it doesn't always happen the other way. Another question from Mary Ingram here. She's observed that that when she's asked people about making these changes,
Mhm.
that it can be challenging. So what one of her questions is, they respond, maybe I could focus on one of these, but I can't change how I sleep, how I eat, and how I move, get light, other things. Would you be able to say yet in the research, if you had to focus on one of these three, which you would focus on, or whether small gains in all three might be preferable?
Yeah, I love this question. So my short answer is no, but ish. So no, I don't think we know enough yet to know which lever matters most, but it is a whole system. And so I think what the patient is saying, and this is something that I actually typically do as well, is what's a measurable change you can make now? What do you feel most likely to succeed at? And this works for a couple of reasons. If you can get in buy-in on the one thing that they're willing to make some changes on, it will shift that whole transduction process, right? We're trying to, or that's the idea, is that we can shift the whole biological cascade. And so thinking about, for any one given patient, which one are you most interested or most likely to want to change? I do wonder if coming up with measurable goals for each one that are small but reasonable might shift the system instead. But this is, I would say, a big question in that first bullet point of our program of research. Jen, I see that you have had a question for a while, but are in Tony's blind side.
No
So-
worries. That
All right, this will be our last one. There's more online. People are really interested in what you're saying.
Oh, lovely. If we collect them, I'm happy
Yeah.
to answer them and send a Tony-esque video.
Yeah. Well, first of all, Anna, thanks so much for a really thoughtful and thought-provoking presentation. It got me thinking about the language that I sometimes hear and I've used myself to communicate around safety planning. And often the terms I hear are, we're going to develop this plan to keep you safe, right? And while that is often our primary concern and the concern of maybe other people in that person's life, that's not always ultimately their concern. They don't care so much about their safety. What they care about is reducing suffering, feeling better, right? And so I think this model with the focus on health behaviors really fits into that. One thing I'm wondering about is when it comes to those behaviors, how you'll think and maybe incorporate into your initial kind of exploration, social determinants of health, since for some of these, they can play a role when it comes to food deserts or environments suitable for exercise, things like that. So,
Yeah,
thanks.
that's a great question. And I think actually the primary theory I draw on highlights this a little bit, that these are relevant factors. I think the approach that in at least the short term I'm taking are what's within your capacity to change. Some people are not going to have the resources to do some big fancy diet or the capacity, but what are small changes that you can make? What do we have control over? The last thing I'll say, because I see you giving me a time look, is that the language really does matter. The phrase that I like to think of and the thing that I truly think matters is, what do you need to be well? So yes, we want you to be safe, but what do you need to be well? And I would say that drives me.
So Anna, there is a lot of questions that you have laid out in front of you for your research, and I think you've generated many more here today. So we look forward to watching you as you go about trying to answer some of those questions and see how you can change the field. Thank you very much.